So the way I see this program working is that we're going to do maybe 3 or 4 vignettes of, what your life could be if you're diagnosed with breast cancer and what the kind of decisions that you need to make. So we base it on 3 or 4 different scenarios, medical scenarios, and Dr. Choi will then help make the decision in kind of like real life time and what does happen in a physician's office. So I think it's going to be very interesting to see that and the kind of questions that come up and the issues. So we're going to have 4 chaperones or 4 patient advocates. Brooke is going to be one. She's a nurse practitioner. Ivis is going to be one who represents SHARE. And we're going to need 2 more advocates who could step in on the podium in the second and third vignette and ask questions. So is anybody interested in doing that? Okay, so you know what? Brooke will do 2, and Ivis will do 2. Okay, and then we're going to break, and Dr. Choi has a small presentation that's brief, and she'll go over some of the schematics so that you can visualize what she's talking about. And Ivis wants to speak too.
Just a quick second.
Ivis, come up.
Thank you so much for being here. I'm Ivis Sampaio. I'm the Senior Director of Programs at SHARE, an organization that has been providing support services and education to women and their family members who have had breast or ovarian cancer. And I'm very happy. This is my doctor, Dr. Axelrod. I'm very happy that we've been able to do a lot of work together with NYU and collaborate. She's also on our board at SHARE. But also, especially with the fact that this is a very intimate program, we're hoping more people are able to join us. But I wanted to also thank all of you for braving the weather and making an effort to come. We have materials outside and information. So any of you who are interested, our numbers there. We have educational programs, webinars, support groups in various languages, and our helpline that has a volunteer who's a peer that will respond to you, refer you to other peers. And we have 19 languages that we provide this support services in. So if you have any questions, as I said, we have materials out there, and I can always give you my card. Thank you.
Knock, knock.
Wow, the doctor's here very quickly. Oh,
No
great.
wait time. Hello.
Hi.
Deborah. May I call you Deborah?
Absolutely.
I'm Mihye Choi. Nice to meet you.
Nice to meet you.
I'm Brooke, her granddaughter.
Oh, God.
Nice to meet you as well.
Yeah.
You may be older.
So Deborah, tell me why you're here.
So I went to have my mammogram, and this was my routine mammogram that I have every year because I'm over 40, and I have a large area of intraductal cancer, and my doctor said it's stage 0, and then I'm going to do fine, and that I probably will not need any treatment other than maybe radiation, but it is a large area, and my surgeon, my breast surgeon, said that I should go see a plastic surgeon and see what my options are.
Okay, great. So are you thinking about lumpectomy or mastectomy? Did they offer you what is preferred treatment for this?
Well, my surgeon said that I should really consider mastectomy, but I've never been shy about my breast size, so I'm okay with being smaller, but I would rather not have a mastectomy if I can avoid it.
What cup size bra do you wear?
Well, I'm like a triple D.
Okay. Did you ever feel that your breasts are a little too large and you want to be a little bit smaller?
Absolutely. I've always thought about that.
Great. So I would speak to your breast surgeon and really discuss, but you could benefit from doing breast reduction at the same time as lumpectomy. So we can do that in the breast with breast cancer. and then we can do breast reduction on the other breast to match. So that's a great option for you.
So my grandmother is very concerned about symmetry and are the breasts going to look the same? Will they look the same, and will radiation affect what they look like at all?
Yes.
Thank you for that.
So, a lot of times what we can do is we can try to make the breast with the breast cancer slightly larger, because radiation can make the breast constrict a little bit and make the breast smaller. But having said that, I may not have a lot of choice during the surgery, because number one thing that we want to accomplish is take the cancer out and have a clear margin. So I'm going to see what is left behind, and then with that tissue, I'm going to try to shape a breast, and I'm going to try to match with the right side. So, I guess what I'm saying is I can't really guarantee exact match, but I think that we can make the breast look very similar.
And what if I decide that I want to have a mastectomy instead?
You can do that as well. Obviously I would examine you, or do you want to get naked here, or?
No.
So she has very large breasts. Is saving her nipple with a mastectomy still an option, or only with the lumpectomy?
It's probably not an option with mastectomy, because you're very large, and the DCIS, we have to see the exact location of the DCIS and how close it is to the nipple. But if the breasts are very large, it's difficult to save the nipple.
Yeah, I did speak to my surgeon about that, and they said it would be very unwise to save the nipple because of the size of my breasts, because I'm very large-breasted. Mm-hmm. But they said to defer to you.
Okay. So I agree with that opinion. I mean, so with breast reconstruction, if you're having a mastectomy, so you could choose not to have any reconstruction. You could choose to just arrange some local tissue to make it look nice and have maybe small breast mound. Or thirdly, you can have implant-based reconstruction. And the other option is using your own tissue for breast reconstruction. So those are options which are available to you. So if you don't mind being smaller, then we could do direct implant reconstruction, and you would be done with that reconstruction on the left side. We could reduce the right breast or the other breast to match at the same time. So, in that case, I have to really assess your mastectomy flap, we call it. That's just the skin remaining after mastectomy is done, to see how healthy it is, how vascular it is, and I'll make the determination during the surgery whether we can put an implant directly into that area.
What if we need radiation?
You can get radiation with the implant in there. You can have radiation with nothing, or tissue expander or implant. Only thing which is not good is having the flap radiated, because the flap can really become hard and fibrotic. So most people would decide to do the flap surgery later, after radiation is finished.
I've heard that she may have drains after this surgery, and they're terrible, and she might lose range of motion of her arm. Is that true?
The short answer is yes, but we're going to be here to help you. The drain is necessary because whenever you take some tissue off from the body, there's a cavity, and the cavity accumulates your own fluid inside, and it gets swollen. So the drain drains that fluid out, which actually makes the healing faster. So if the area is full of fluid, that would delay healing process. So the drain is necessary, and we would remove it as soon as you're ready. And taking the drain out really doesn't hurt because the drain technologies evolved so much that they can just sort of slip out, and not to be afraid of that. And the range of motion with just simple mastectomy and maybe lymph node sampling or biopsy, that we don't really want you to move your arms too high or lift heavy things, and you have to rest your shoulder and arms so you can achieve very nice and good healing without problems. You know, if you use it too much, or then you can pop a stitch, or you could have a bleeding. That's why we want you to not use your arm and shoulder too much during immediate healing phase. But after a week or 2 weeks, you can start gentle range of motion. And then if it is still stiff, we can send you to therapists, physical therapists or rehab physician to get your motion back.
So can I get back to, if I don't have a mastectomy, if I have a lumpectomy, do I stay in the hospital?
You don't need to. So we can plan on having you not stay, but after the surgery, for whatever reason, you don't feel up to going home, we can keep you overnight. So we really go by how you feel and how you recover.
And obviously that's if you do the reduction on the other side.
Yes. You don't have to do it at the same time if you don't want to. It's really your choice, but most people want to wake up and be balanced. So that's something we offer to do.
Does insurance cover this?
Yes. The Women's Health Act covers any surgery related to breast cancer in the breast which has breast cancer or the contralateral, the other breast as well.
So if I have the lumpectomy and decide that I want to delay the contralateral breast for the symmetry or the other, the other breast, then will it be covered once I decide the healthy breast?
Yes, you can decide at any time. Right now, the law covers the other breast surgery basically any time after cancer diagnosis. So you could do it a year from now, you could do it 10 years from now, whenever you feel ready to take
I'm a grandmother, I don't have a lot of years. You know what I mean?
Grandma, it seems like waiting for the healthy breast until after radiation might be a good option, because then you could get better match after the effects of radiation have happened.
A downside is that you may feel kind of lopsided for
about 6 months.
Maybe, yeah. So, but that's a short period. I mean, I think that whatever
maybe not for me.
Whatever makes you feel comfortable, I think we can do that.
Anyone have any questions?
My question is a little bit different, but since we're talking with a plastic surgeon, I had a bilateral mastectomy, and right now I'm with the tissue expanders. And soon I have the second surgery for the actual silicone. And my plastic surgeon advised me that in my case, because my skin is very thin, it's better to have the silicone instead of have just the silicone. And the brand that they're putting, it's called Allergan. But New York Times, they came up with an article about Allergan, that actually Allergan, the silicone Allergan, brings breast cancer. So what would be your advice? Should they just change the brand, or what do you think about that?
Yeah, no, that's a very, very pertinent question. Actually, our office had phone calls, about 10 phone calls a day after that article came out. And also, that specific implant by Allergan that is related to this local lymphoma, it's called the ALCL, that implant is recalled. That means you cannot use that implant even if you wanted to. So the implants that your surgeon is recommending for you is not those implants. So you cannot use them anymore. So I don't think you have to worry about that. The Allergan, although it is cited to have the highest instance of ALCL with their textured implants, the rest of the implants are really not problematic at all. And Allergan is most used brand, and it is best followed and best studied. So I think the brand itself is not a problem. The other companies such as Sientra and Mentor were cited for having incomplete follow-ups on patients. So just because they're Allergan doesn't mean you are getting inferior product at all. I would consider that maybe the best product available. So I think you can feel reassured that that's a good advice. In terms of saline implant versus silicone implant, that's a personal choice. You can actually feel them in the office and you can compare what you like. It's difficult to appreciate the difference when it's not inside of your body, but you can like simulate by putting a blanket or towel on it and try to feel and how you feel. The saline implant is kind of similar to the tissue expander. So you already have a good feel for what they're gonna feel like, except for the hard metal port. So if you feel around the edge of the implant, with the saline implant, it's gonna feel very similar. So if you're fine with that feel, then saline implant may be fine for you. But if you feel that that feel is a little bit hard and you don't like the wrinkles or the way it feels, then maybe silicone implant will be better. So I have to say, in my practice, 90% of the patients choose a silicone implants because they feel more comfortable.
What about the valve? Don't you also, you have the valve and the saline, and don't you always feel that? Do they make them smaller now, or are they still, because they're kind of large?
Yeah, there's actually valve can be anterior in the front or posterior. So you can, the valve is sometimes palpable from outside. So you could choose a valve implant with the valve in the posterior aspect, which would be less palpable. But it's never really a problem. The valve is very small. But one thing about saline implant is the valve is the weak point. So if the saline implant leaks out, it's usually through around the valve. Because the valve is not integrated into the implant, it's a piece they stick it on. So it could leak around it or through it. So that's one point that which could be vulnerable. But I feel that both types of implants are fine and they're healthy and they're not problematic. So I think it's really purely by which one you prefer.
Thank you so much. Can I just ask one more question?
Ask away, to Granny or to the doctor?
Doctor.
She's a doctor too, you know that, right?
Whoever is
like,
able to tell me. And do you think that after the 10-year, most of the doctors, they recommend to change the silicone? So in some people they do it, some people they don't. So
the 10-year is like a little bit of a misnomer because they guarantee it for 10 years, the implant companies. But it doesn't matter to you because you have a diagnosis of, you're related to breast cancer, whether it's a risk or breast cancer. It will be covered no matter what. It's for, really that was designed for augmentation patients. They do it for cosmetic reasons. So if they leak or rupture implant, something happens to the implant, they guarantee for 10 years. So they would give free implants to you. So that's where the 10-year comes from. The current implants are 5th and 6th generation implants. They're really, really good for a long time. Some plastic surgeons are telling patients they're good forever. And I'm not telling that because nothing man-made are really good forever. But I recommend that we change them if there is a problem. It's not an automatic thing. Just because you change it 10 years, the next one's gonna be good for 10 years. You don't know that, So if you don't need the surgery, I wouldn't volunteer to have a surgery. So.
You look young. That would be setting you up for many, many more surgeries.
Just the whole pain and everything. I can imagine that again I will go in a hospital. And I had a really bad experience the first surgery. Now I'm super stressed about the second one. And imagining that after 10 years again I have to go in the hospital to change the silicone, just the idea of it.
Do you ever leave an expander in and not replace it?
I've never done that. I had one patient who had a thriving landscaping business in Brooklyn. So I put a tissue expanders in, and she looked fine, and she felt great. And so she didn't have her expander exchange for 2 years. And I begged her to come back to have the tissue expander exchange. I mean, it's not dangerous, but tissue expanders are usually not as comfortable as implants because they are harder, there's a metal part to it. So generally it's not recommended, it's not designed to stay in there for 10 years.
Does it matter if I sleep on my stomach or I'm a side sleeper? How will I feel if I decide for some wild reason I want to remove both my breasts and put implants in?
Yeah, I wish I had a better answer for that, but basically I don't recommend patients to sleep on their stomach. On their sides are okay. If you roll over to your stomach, that's fine, not to panic at all, but get out of habit of sleeping on your stomach because you're putting pressure on your breast, and that will make your implants maybe, it's not because of leakage or rupture, if I stepped on it or threw it across the room, or you're wearing a stiletto and stepped on that implant, it's not going to leak or rupture. The reason for leakage and rupture is everyday wear and tear weakens, some part of the wall and the gel or saline can leak. That's usually the scenario, but I think that the sleeping on your front will just make your implants smushed and maybe go a little lateral. So I don't think that that's a good idea.
Thank you.
Welcome. So what did you decide? Deborah, what do you want to do?
Well, I always say that they're sisters, not twins. I don't want them to be distant relatives, so I'm okay with doing the lumpectomy and the reduction.
I think that's a great choice. Actually, you're not that old at all, so I'm not including you in this group, but there was a study looking at people who are older than, I think, 65 who had a lumpectomy and reduction. Those people are extremely happy with that. So if it's an option, I would strongly consider that because you just look normal. You're just lighter, you're lifted and smaller, more comfortable. I think that's a great option for people to do lumpectomy and reduction.
Scenario 2.
Oh, she's making me work today. Okay.
You'll be my sister.
Okay, good. Right.
Now, this time you're a sister, not
Yes,
a granddaughter.
Okay, well, where's
You want me to
this
come?
doctor? Jeez, we've been sitting here forever.
Knock, knock. Hello. Deborah, it's very nice to meet you. I'm Mihye Choi.
Hi, very nice to meet you.
I'm Brooke, I'm her sister.
Oh, nice to meet you, Brooke.
She's my older sister.
So Deborah, tell me why you're here today.
So we have a strong family history of cancer in the family. And so our other sister got tested for a genetic panel test, blood test, and she tested positive for the BRCA1 mutation, and it was recommended that we also get tested, and I tested positive and Brooke tested negative. So I'm here to discuss what my options are because I am so young and I would like to know what my options are for my breast, and then if I decide that I want to do something with my ovaries, what the timing of the surgery is for both.
Right. Have you met with an oncologist or a surgical oncologist?
So I met with the breast surgeon who referred me to you, and I want to meet with a gynecologic oncologist, but I haven't met with them yet.
Okay. So have you decided that prophylactic or risk reducing mastectomy is something that you would like to do?
So in a conversation with my breast surgeon, I understand that my lifetime risk is very high of developing breast cancer. I am 34 years old. And I think that I would like to do it. I have my 2 children, I breastfed. I'm not interested in getting pregnant. Yeah, I think I'm ready. I've thought about this. I've known about this for 6 months, and I've thought about it a lot. And I feel like I'm ready. I spoke with my husband about it, and and my family and my sisters, and I think it's right for me.
Okay. Tell me a little bit about your family history of breast cancer. Did your mom have a breast cancer?
So my mother had breast cancer at the age of 50 and passed from heart disease. My older sister, who was BRCA, had breast cancer. She had a triple negative breast cancer. So she had an estrogen negative, progesterone negative, and HER2 negative breast cancer, which is really why she got the BRCA mutation, where she got tested because of her triple negative. They say that the BRCA ones, if they get breast cancer, it usually tends to be more aggressive. Mm-hmm. But we really don't have, other than that, a substantial history.
Mm-hmm. Did your mom have mastectomy done?
No, my mother had a lumpectomy.
Mm-hmm.
And she didn't get tested. She died of heart disease.
I see. How about your sister? Did she have mastectomy done?
So our older sister, she had chemotherapy first, and then when they tested her and she was BRCA positive, she then underwent bilateral mastectomy.
Mm-hmm. What kind of reconstruction did she have?
Bad one. She's very upset.
Well, tell me about why it is bad.
Well, so she had a mastectomy and she had radiation, and the implant, it had an opening in there, and they had to go back in there, and then they had to leave her without the implant, and then eventually, 4 months later, they had to take something from her back, and they had to, I don't really understand, but they had to do something where she's very unhappy with the results.
I see. So, one thing, if there's anything good about it, doing prophylactically, you will not have any issues with having chemotherapy done or radiation therapy done. So it becomes more of just a surgery and healing. So no adjunctive treatment is needed. So that really stacks your cards in your favor that you will heal well. So I think you are in a different scenario than your sister, thankfully. So I would examine her at some point at the beginning, and I would assess whether you are a nipple-sparing mastectomy candidate or not.
I'm like a B cup.
Right. So if the person is A or B, even C cup, and their nipples are not really very low, they can actually have nipple-sparing mastectomy. So that means that nipple will be saved, and we can do mastectomy through an incision, either underneath your breast or side of your breast. We can design that incision with your breast surgeon to see what would be the best approach. So when we save the nipple, the good thing is that there is a very good chance you're going to look normal after surgery, like somebody who really didn't have a mastectomy done. But however, it doesn't mean you have nipple sensation. So nipple sensation will be gone nonetheless.
Do you have to put some plastic covering in there?
Right, inside of your breast, you mean? Like implants?
No, over the implants.
Oh, well, so, so with the reconstructive choices, you can do implant-based reconstruction or your own tissue. You said you're done with childbearing. So I will examine your abdomen. So if there's enough tissue there, can you stand up for me, Deborah? Let me take a look at your tummy.
I know, but there is
Okay, there is enough there. So we could use your own tissue to make your breasts. That's one option. So good thing about that is once we do it, it's good forever. And if you gain weight, it's going to get larger. If you lose weight, it's going to get smaller. They're going to feel very comfortable. They feel very natural, and so that's a great way of doing it. So that's one way of doing it. The other way is doing implant-based reconstruction. So implant-based reconstruction with nipple-sparing technique, we can put implants directly in, or we can put what's called the tissue expanders in. So tissue expanders are temporary devices that we can put in, which is not inflated right away. So we let your skin and the nipple all heal well, and then you come and visit me periodically. It could be every week, every other week. If you go away for 2 weeks, it's fine. And so we inflate little by little to create your breast mount. And the great thing about that is you can say, this is a good size for me. I want to stop here. I want to be bigger. I want to be smaller. So you have the control over the size. But downside is you need a second operation where I take the tissue expanders out and put implants in. So that's one approach with implant-based reconstruction. The other approach is put implants directly in. So if I do that, then I may need a covering. So what that is that when the mastectomy is done, mastectomy is not like just taking breast tissue out circularly. Mastectomy goes all the way to the breastbone, all the way to the side, and all the way to your fold. So it's a big area. So it's not a small pocket you can just pop an implant in. So I have to create a pocket to put the implant in. So we use either a mesh, or we actually use a cadaver skin. It sounds kind of scary, but it's a dermis. It's a radiated tissue. All the cells are gone, all the DNA is gone, all the bacteria and virus are gone. So I can make an internal brassiere with this tissue and put our implant underneath it, and your own skin will cover everything. So you're not going to see any of this material, but it's an internal support for your breast. So in that case, if you choose to do one-stage reconstruction, there's a very good chance that I would need that to support your breast and implant. Does that make sense? Or
It does.
So if she does it
You want Dia? Okay.
No, the visualization.
Oh yeah. So well, you're not a good candidate for that because you're only a B cup breast. Yeah. But if you're very large breasted.
Oh. So I guess the question is,
we've heard that in some instances you can use other parts of your tissue to protect the implant aside from having a mesh put in.
Oh, that's your question?
Yeah.
Okay. Okay. So sometimes I don't have to use this cadaver skin or mesh. I can use her own skin to support the implant, but it's only good for people with very large breasts. So they have very excess tissue. So then I can take the top layer of skin off and just have the dermis to support your implant. And I can put her own skin over it to create a breast. So that's also possible. But with a B cup, I don't think you're going to have a lot of excess skin I can use for that.
If she gets the direct to implant surgery, that means she's all done? There's no chance of needing anything else?
Yes, that's a very good question. So we could do it one stage in some small breasted woman and be done with that. But the rate of touch-up surgery is about 30%. So it doesn't mean something is wrong, but we aim to please the patients. So they may say, I want a little bigger implants, I want to be more lifted, I want more fat graft, or there could be some other issues they want us to address. So that overall rate is about 30%. So it's one stage reconstruction in a sense that you go to sleep and have mastectomy done and your breast is reconstructed in one day. Actually, Dr. Axelrod and I wrote a paper. It's called Breast in a Day. And we were featured in today's show, so you can actually Google that and look it up. And she's actually our patient, and she got married, and so there's some beautiful story to that. But so it can be done in one stage, and you could be candidate for that as well.
If I had a reduction beforehand, so 2 questions, just for the audience. One is if I'm, let's turn the tables for a minute. I'm very, very large breasted. I'm like an F, right? I'm an F. And I really want to do nipple sparing. I don't have breast cancer, but I do have the mutation. And I do want to do the surgery, but I really don't want to lose my nipples.
Yeah, so this is something new that we are offering, is that we can actually do a breast lift or breast reduction first. In your case, it would be breast reduction. So what that does is that if the breasts are very large and nipple is very far away, it's difficult to save the nipple, because main reason is the circulation to the nipple is cut off. So nipple will not heal even if you saved. But you can actually reposition the nipple by reduction and mastectomy to a good position. And
What's a mastectomy?
That's a breast lift to a good position and let that heal. And what happens is circulation to that nipple reconnects into the new position. Then we can save the nipple. So it's doing it in like 2-stage or stepwise fashion. And it's a great way to save nipples for people who do not want to do.
How long do you wait?
Minimum, I want to wait 3 months. But longer you wait, it's safer because more blood vessels will grow into it and it will heal.
I'm curious, why would anyone not want to save their nipples? In what situation could you not save your nipples?
Right. So if somebody presents with very bad breast cancer and their nipples are very low and not in favorable position, and so they cannot take time lifting the breast or doing something else to it because they want to get rid of that cancer right away. And then second reason could be if the cancer is too close to the nipple. So there's a lot of research is done, and we generally recommend at least 2 centimeters away from the nipple. So we would look at the MRI scan. Actually, the breast oncologist will look at it and recommend whether it is savable or not. If it's too close, then we cannot save. And also another thing we do is if it's a borderline at NYU, we actually do a biopsy under the nipple during mastectomy to make sure it's clear before saving it. So when we call that frozen section. So if we do frozen section and frozen section comes back positive, it has breast cancer, then we can immediately remove the nipple areola. If it is negative, great thing about that is that if it's negative, then we can save that. We do have to wait for the final pathology at the end, and there are very few cases where it came back, frozen section is negative, but the permanent section is positive, then you can always take the nipple off then. So there's nothing to lose by saving it.
Yeah, we actually, just as an aside, we're actually looking at doing nipple sparing for even if it's a centimeter within the nipple on MRI.
Yes.
So, I mean, we keep pushing
The envelope
to do that.
Yeah, that is actually a paper Dr. Axelrod and I and other people at NYU wrote, is that between 1 to 2 centimeters, if you do frozen section, if it's negative, it's safe to save. So we follow these people out, average of 5 years, and really there's no recurrence of breast cancer in the nipple itself. So we feel very confident that this is a safe technique. Obviously, nobody can guarantee that, but so far it seems to be as safe as not saving the nipple.
So since my sister is having risk-reducing surgery, and then the breast tissue will be removed, and are you leaning towards implants, sis? Or the flap? I'm curious what her follow-up long-term is. Does she ever have to see her breast surgeon or you again if she goes through with implant surgery?
Yes, I like to see my patients every year, and also her breast surgeon would like to see her periodically as well. We will follow with you to make sure implants are not leaking or ruptured. There's nothing to worry about. We would carefully examine to make sure there's no skin changes or nodules or problems. So we like to see you every year.
Okay. Can we break now, and can you give us some of the schematics, and then reconvene and do another case? How's that? Because I want to talk to you about no reconstruction too, about going flat.
Yes, ma'am.
Okay.
Okay, very good. So I've been working at NYU for about a little over 20 years, and I work a lot with Dr. Axelrod, and she taught me a lot actually when she first came, because she was already an experienced breast surgeon from BI and from and St. Luke's Roosevelt. Yeah, so yeah, and this was sort of like, it wasn't my very first job, but close to it. So working with a really experienced breast surgeon really opened my eyes, and I think that this really made me into a better plastic surgeon, and really working together brings a lot of joy, and we can push each other to do better jobs. So I think that that's like one thing that I really enjoy in my work, is working with colleagues that I respect. So like this was a patient that I saw many years ago. Reconstruction was done 40 years ago by some other plastic surgeon, and this patient, the light, yeah. Can the lighting be dimmed in the front a little bit? So, this patient was not unhappy. She, back then you could have nothing. She felt that she could wear a bra, she could even out with the bra, and she was happy with that. But so this was kind of result that we were looking at 40 years ago. This is my own patient. When I started to practice, the patient obviously has right breast cancer, and she has implant reconstruction. And 20 years ago, I was happy to have this kind of result. She's more even, she felt comfortable, she was happy with this result. But nowadays, what we try to do here is we try to get this kind of result for, if possible, every single patient. So she had a nipple-sparing mastectomy and through an incision underneath her breast, and then we did a direct implant reconstruction, so one stage. So in select patients, when selected well, you can get this kind of result. So that's what we aim for. So really a lot of innovations and game changers occur. And I think the main reason is because we understand that this is a team effort. It's not just about the plastic surgeon or a breast surgeon. Implant technology has evolved significantly. We have 6th, 7th generation implants. And actually, I have to tell you, we're part of studies looking at implants made in foreign countries from Costa Rica and Korea. And there are actually really good implants out there. And there will be more, better implants available to people as we go on. And we are doing flap surgery. That's a flap from, meaning your own tissue without sacrificing muscles. So it used to be you had to take the entire muscle to make a breast, but we don't have to do it anymore. It's called a perforator flap surgery. That means we save all the muscles. So these are some of the progresses that we made. We want to make the breast look natural. We wish they are sensate. We are working on that. We want to make them symmetrical. We want to have a minimal scar burden, and we want them to feel soft and nice. So my aim, and Dr. Axelrod's aim, is we want the patients to forget they had a mastectomy and reconstruction. We want them to play any sports they want. The sports that I listed here actually are actual patients of mine. These are people who are doing curling,
there are professional yogis. I mean, there are lots of people doing all sorts of stuff after breast cancer surgery. Can wear any type of bikini top or gowns and feel confident and sexy no matter what. I'm not saying breast reconstruction make you feel sexy and confident. No matter what you choose, we would like you to feel that way, and we're here to help patients achieve that goal. And our philosophy in what we call ideal breast reconstruction is really, I think of it as more like haute couture or wedding gown fitting. I don't believe there's one ideal dress which is perfect for everybody, and we want to individualize. I think that we pride in that. NYU is not a place that we have hundreds of patients processed through, and we have algorithm, okay, you go do this and you go do that. We don't want to approach it like that. We like to pay attention to each patient, and we like to talk about what the patient does, about their children, their jobs, and we want to do the right operation for you. So as we briefly discussed, they can be implant-based or flap-based. They can be direct implant or two-stage reconstruction. The deep flap, the perforator flap we talked about from the abdomen is the most common flap that we use, but there are many other flaps available now. With direct implant reconstruction, we want to have this kind of result. This is a good technique for small to medium breasted women who are candidate for nipple sparing or not. We can offer sometimes direct implant reconstruction. If the patients are very asymmetrical, they want to be larger, then two-stage approach is a great approach still. So this patient had a tissue expander, had an implant, but she wanted to be even larger, so she got a larger implant, and the patient is very happy with this result. This patient decided to do a flap surgery, so here she is. It's not nipple sparing. We did the nipple reconstruction and tattoo, and after everything heals, she feels extremely comfortable and soft. Here's another patient, even with one-sided breast. This is right after the surgery. The scars still healing. They're still a little bit hard, may not look great, but once we do the nipple reconstruction and tattoo and lift the other breast, the patient feels actually completely natural. This patient is extremely happy with her result. So there are many things we can do in adjunct to actual breast reconstruction, such as fat grafting or lifting the breast. And there are many things which are possible. So although some breast surgeons don't like fat grafting, but fat grafting could be a great technique. This patient had a deep flap to both breasts. She had a very small stomach. There's a little skin patch you see, that's from the abdomen. So the second stage with touch-up surgery, you can get rid of that skin patch, and I did a fat graft, right breast 85 cc and left breast 54 cc, and you can make the outline of the breast smoother and make them look more natural and make them a little bigger. So the fat graft can be a very good adjunct. Here's a patient that I actually happened to see her today, but she had a right breast lumpectomy and radiation. So sometimes people think breast conservation therapy is a great treatment, and it is, but sometimes you don't get a good match, or patients are very uneven and scar can be very bad. So she had a recurrent breast cancer. She had a bilateral deep flap stent. Right after surgery, scars don't look that great. She's still healing. But after a year, I did a nipple reconstruction and tattoo, and scars fade, and she's just very, very extremely happy. Actually, she's from England, and her sister had a breast cancer surgery, bilateral mastectomy 10 years ago. Back then, England did not cover breast reconstruction, so she never had a breast reconstruction done. So I told her the British law just recently changed and now it's covered. So I have some friends in England, so I'm going to give them the names, and she's going to go see a friend of mine in London for breast reconstruction 10 years down the road. So all these are possible. I just want to say that I believe we can do better than ever, despite all the bad press in New York Times. But I think it's really a team effort, really working with somebody like Dr. Axelrod And working with medical oncologist who does chemotherapy, timing of the chemotherapy, neoadjuvant chemotherapy, and working with radiation oncologists when is the patient ready for radiation, when's a good time to do flap surgery, and working with rehab doctors, really gaining the full range of motion, getting the swelling down, and working with nurses who are really instrumental in making the patients feel more comfortable, and they have somebody to talk to and really help take care of issues which may rise. But number one, the team member is the patient really, and the patient really actually have to help themselves and the doctors too. I want the patient really taking an active role in healing process and feeling better. So I believe she is the most important person, and obviously her family and friends who are the support system for her. So I truly believe it's not just about me or the doctors, but we do it all together. All right, I guess my talk.
I think that we'll do one more quick case because I think it will illustrate the recovery from a larger operation. So let's do that. Brooke, why don't you come up, because I think that this is like right up your alley. Yeah. Wait.
Oh.
Get out.
I have to knock again.
Don't be such an on-time doctor, okay?
You actually,
The rest of us,
Knock, knock. Hello.
Hi.
Deborah. May I call you Deborah?
Yes.
My name is Mihye Choi.
Hi.
Nice to meet you.
I'm Brooke, her partner.
Our partner. Nice to meet you. Very good.
She must think I have like 18 breasts here.
So tell me why you're here.
So I have a breast cancer, and I just finished chemotherapy. I had a HER2 positive cancer, and I had what looks like a complete response on my imaging. Very, very excited about that. And I am now here to discuss surgery. I don't want an implant, and the way I presented initially was the cancer was very diffuse, but my lymph node clinically never showed anything, and my doctor said because it was just pockets that I may not need radiation. So I'm hoping just to have a mastectomy and talk about what my options are, but I really don't want an implant. I don't want anything fake in my body.
Okay, I understand that. So your options are basically, I would say, using your own tissue. So the most common area to take the tissue from is from your abdomen, and I'll examine to see you have enough there. She has plenty. It'll be okay. So that's the one option. I just want to mention that you are here with plastic surgeons, so you're interested in breast reconstruction, but it is your choice. You do not have to do reconstruction. So that's another choice. Some people decide to do just mastectomy, and I can just rearrange your tissue a little bit so that you have a little bit of something in your breast. So that's another option. Well, how do you feel about that?
Well, we talked about it, and I think that I would like to go for the big guns.
Okay.
Yeah, we read something about a tummy tuck and breast reconstruction.
Yes. So we take a tissue that if you have excess tissue in your abdomen, we can take it from your abdomen, and it's based on a blood vessel. So we look at your blood vessel pattern, and it's based on your what blood vessel looks good to supply that area, and we can take that tissue and transfer to your breast right after mastectomy and connect the artery and the vein to reestablish blood supply to that area. And it's a great option for people who don't want to use implants because they are very soft and natural, and once they're healed, they're good forever.
So I have an unusual job, and I also really like kayaking. I'm a big kayaker. Does that mean I can't do that sport? And when can I get back to doing my auctioneering at Sotheby's?
She's the breadwinner. How long is she going to be out of work?
Well, auctioneering, you have to be confident, have a strong voice, and you have to command the room, right?
Absolutely.
So, yes, ma'am. So I think you can go back to work, I would say anywhere between 1 to 2 months without a problem. In terms of kayaking, it may take 2 months, but using your tissue is a great technique because your pectoralis muscle and latissimus dorsi muscle that you use to kayak are not touched. So they're going to be strong as before. And then we can just add your own tissue from your abdomen, which is basically fat, to your breast to create breast mounts.
Can I get a hernia?
Yeah, that's a very good question. So it's very rare for you to get a hernia because we don't really take your muscles anymore. It's based on just the blood vessels, so it's a perforator flap, so we don't sacrifice your muscle. When in the past, when they sacrifice muscles, that's when people used to get hernia or a big pouch. But having said that, with this type of surgery, it's not that rare to see maybe slight bulge of your muscle where the tissue is taken from. So we make you as flat as possible, but as you heal, because you're missing some of the tissue, you could develop slight bulge, and we would consider that normal. It would be not even how it is now. It would be much flatter than you are.
Do you have to close it with a graft, or do you close it with like my own tissue?
Yeah, often your own tissue, but if your own tissue is very weak, we may use some support material, usually a mesh to put in there. It's just a suture mesh. It's nothing like the bad reputation with the bladder suspension mesh. It's completely different. It's a suture material to reinforce your own repair.
Connecting blood vessels, that sounds complicated. How long does this surgery take, and how long are you in the hospital?
Yes, so it takes a long time because it's a microsurgery. It's done under a microscope. So, having said that, it's not really a dangerous surgery. I'm not operating on your brain or your heart or lungs, but the vessels are like 1 to 2 millimeter in size. So we are extremely careful, and that takes a long time, but we do it very fast at NYU. For both breasts, it'll take about 7 hours. And the way we do it is when the breast surgeon is doing mastectomy, we're already raising your flaps. And then when she's done with the mastectomy, we start transferring the tissue. And we have another plastic surgeon usually closing your tummy like a tummy tuck. So we're constantly working on your body and making the duration as short as possible.
Can you say a couple of words about using the thigh and the butt? I mean, the thigh, the buttock, the gluteus.
Yeah, those are sort of like secondary choices. When I say there are secondary choices, there are a few reasons behind it. But the thigh flap is called the pap flap or tuck flap or duck flap for all these acronyms. But it just means that we take a fatty tissue in inner thigh area. Pap flap is a perforator flap, so you don't sacrifice any muscle. But the other flaps that I mentioned, duck and tuck, do sacrifice muscle, but that tissue is moved to create breasts. The issue with those flaps is that the volume is never enough to really create nice sized breasts. So at best you can create like small B cup, usually like A cup breasts. So because people who are have a large tissue there, their breasts tend to be larger. So it's not the best choice to replace the volume. And also the scar is not so pretty because the scar is right there, near your vaginal area. So
we do think that it is not as good as if you can take tissue from your abdomen. But some people absolutely have no abdominal tissue or they had a tummy tuck, then we would go to those areas. We can also take it from the buttock area. And so the buttock area is also secondary choice. The main reason plastic surgeons don't like that flap as much is because the blood vessel length, because we have to rehook the blood vessels in the chest. That blood vessel is very, very short, that where you can take from the buttocks. So it has a higher complication, higher failure rate. That's why we don't like it as much. With the deep flap at NYU, the failure rate is less than 1%. It's less than 0.5% in our series. So it is extremely low. Most major medical centers cite about 2 to 3% failure rate. So we have one of the lowest failure rate in the country. Because as I said, we have like 2 plastic surgeons working together. We are very experienced in doing it. So from the buttock, it's like difficult to sit. Sometimes like the contour of the buttock becomes weird, so it's not as good a choice. But if somebody had a tummy tuck or they don't have any tissue, it's definitely an option that we would consider.
Do you have any problems with gait?
You should not. Yeah, this is also done perforator flap, so we don't take any muscle with that.
With the muscle, do you?
With muscle, you could get some gait problem or standing issues. But so you have to really check with the plastic surgeon who's doing the surgery to make sure that they're not taking any muscles from the buttock area.
Will I have drains?
Yes, you have. So both drains in your breasts, if you're doing both breasts, and then you have a drain in your tummy. So the breast drains usually stay for about a week. Tummy drain anywhere between 1 to 2 weeks. So it is cumbersome, but once the breast drains are out, I'm going to teach you how you can take a shower with the abdominal drain in, or my nurse will teach you how to do that.
If I decide that I only want to do one side, and God forbid I get another cancer in the other breast, what kind of options for reconstruction would I be looking at?
Right, so if I do the deep flap, we cannot redo the deep flap. Once the deep flap is done, that's gone forever. So we would have to do like a thigh flap or a buttock flap or a back flap. So those are some of the choices you have.
If you do a back flap, can I I like to swim also. Is that a problem swimming?
It could be. The range of motion is limited after that surgery. It takes about a year to get that range of motion back, and you may need a rehab, and it may not be as powerful a stroke. Are you an Olympian?
Yeah, I'm a butterfly person. My bathtub.
So it may add to your speed. It may reduce your speed. So it may not be the best choice for you. So are you interested in your flap surgery?
Sure. Yes.
So if you're going for that, we like to get MR angiogram of your tummy to look at your blood vessel pattern. So that would give us a roadmap of what blood vessels I should go and include in your flap. And I will know that by millimeter where that is by doing that scan. So we can arrange that for you.
How long would I stay in the hospital for?
So the average time of stay for both flaps is 3.6 days at NYU. 3.6. And for one flap, it's about 2.5 days. So it's shorter than ever before. We do what's called the ERAS protocol, and what that is that we use a long-acting numbing medicine in your tummy, because after this procedure, main problem is when you cough and laugh and move around, your tummy hurts. So this long-acting medicine, which lasts for about 3 days, really reduces pain level. So it doesn't mean like right when you go home, the pain's gonna hit you because it wore off. It's not like that. There's like pain is a very strange thing. So if you control it from the very beginning, then your pain level is not as bad. So there's like, we call that pain gate theory, something like that. So you really want to control it right away, your pain level. So there's a whole protocol that we developed, that a lot of people developed together, that which uses anti-inflammatory, blocks nerve pain, and use this long-acting numbing medicine to really enhance your recovery. So it's actually a better recovery than before.
Can you, my girlfriend had the surgery, and then she had some hard lumps that formed, and they did some biopsies and said it was just some dead fat. So can you comment on that? And can you also comment on injecting fat and doing fat grafting?
Okay, she doesn't like that technique. Anyway, the hard fat can occur if the blood supply to that little area is not robust. So that's why the MRA or CTA that we do is really important. We can actually look at in the scan to see how the blood vessel arterizes within your fatty tissue. So believe it or not, we spend a lot of time looking at this, and we try to choose an area or a blood vessel which has the best arterization and best blood supply in that tissue to choose that blood vessel. So there are a lot of hospitals which don't do that, like you know, some other institution down south, in a couple of hours away, they don't do any scans. So we think that like doing this really avoids getting huge fat necrosis or a problem. It doesn't mean your flap is dead. It just means that you can get a hard lump. It can be usually treated by taking it out, or there are different techniques to deal with it if you develop it. But usually it's very small. By waiting, it disappears. So the fat graft is really revolutionized what we can do with breast reconstruction. So the fat graft is basically, we do a liposuction of some area, like your thighs or your stomach or love handles, and then we wash that fat and we can re-inject into your body. So that fat graft, when we do it, only 50% of the volume we put in survives. The other 50%, your body absorbs it like you had, fatty drink or something like that. So that whatever survives will last forever, and it can really make the edge of the flap softer. Even like when you have rippling from the implant or a little divot or problem, fat graft can really smooth out and make it natural. Actually, really impressive thing is the radiated tissue can actually be rehabbed by fat graft. So if somebody had a lumpectomy and had a very horrible radiated tissue, if you can do some gentle fat grafting, the reason we believe it's a stem cell effect in human adult adipose tissue has stem cells, and it can really revive radiated tissue. This sounds like a voodoo medicine, but it's not. That we have really looked at it very carefully. It's a very helpful adjunct to breast reconstruction. There are some plastic surgeons who are just fat grafting and not doing the flap or implant. I think that's voodoo medicine, because you can develop a lot of hardening or oil cysts or fat absorption. So don't do that. It may sound great online, but it's not a great technique. But as an adjunctive technique, I think it has a really good place for it. But as Dr. Axelrod, aka the patient, pointed out, that it can develop tiny calcification or lump or oil cysts. So I always reassure patients that when they occur, that we're going to take care of it, we're going to look at it. It doesn't mean cancer is coming back, and that's what the patients are afraid of. But I can usually aspirate the oil and it'll go away. If you know it's there, you follow it, it goes away. If it doesn't go away, you can always do an aspiration cytology to confirm that it's fat necrosis. I think it's a small price to pay to make the patients feel more natural and feel good. But I don't randomly do these things. I would only do it if I think it's beneficial.
I will say one thing.
Yes, ma'am.
Which is super important for everyone who has any plastic surgery done. know exactly what they had done. So I will see someone who comes in and they will have a nodule and it feels soft and it feels like fat necrosis or an oil cyst. And I'll say, did you have any fat grafting? And they'll say, well, I think I did. Or alternatively, someone would say to me, yeah, my doctor put some fat right there. And I'm okay with that. I'm like, okay, come back in 6 months. But if you don't know, if you don't know what you had done, then you end up with a large workup sometimes that ends up, just in a circle where if you had known that you had the injection in the upper inner quadrant, you would have been fine. So I would just say, advocate for yourself. Know if something is being injected and you know where it's being injected. And if you're a little confused about it, just say, can you draw a diagram and just show me where the injections were so that I know if there's any confusion.
All right. Any other questions? How about, yeah.
I'm sorry, I came in late, so maybe you've covered this already. But for people who are choosing to get an implant, the implant doesn't, if you gain weight or lose weight, then your breasts are going to be different sizes, right?
Mm-hmm. In the one breast reconstruction, unilateral reconstruction.
Yes, unilateral, yeah. So there's nothing you can really do about that.
Actually, you can reduce the other breast or you can enlarge the breast. So I do have patients who come for that. So it can be addressed if they're so uneven that you do not like that. Then you can put like a little bigger implant in. There are many things I would have to examine and really recommend to you, not whoever, what makes sense for them. Unfortunately, it is a surgery, and you have to recover and heal well. So there's an investment that you put in terms of your time and your health to get a better symmetry, a better result.
So did you already cover this?
No, actually, no.
And you can't like gain, lose, and keep having a surgery. You got to pick
No,
a weight.
I figured that. Yeah, I figured that.
Can you mention about the prepectoral versus subpectoral implant?
Right. So this is prepectoral. How many people have heard of that? Prepectoral. Okay. So prepectoral means the implant were always placed under the muscle in America. The reason is because after mastectomy, the skin's really traumatized, so you want to protect the implant and heal well. But the one downside of putting under the muscle is that when you lift weight and exercise, there's a little bit of animation of your breast. So some people really didn't like it. So then some people came up with doing the implant above the muscle. So this is a technique which can be done. We usually, that cadaver skin I talked about. So that implant has to be completely wrapped with that cadaver skin for it to stabilize that implant usually. So it is a possibility. It usually works better in people with a pretty thick subcutaneous fat because the fat, the fat kind of makes it look normal and heal well. If you're very thin and the implant is lying right above the muscle and thin skin covers it, it just looks so odd and artificial. It usually doesn't look right. In terms of the animation, there are different techniques you can do, but animation can be minimized. So it's sort of newer technique. It actually, it's not that people used to do it this way, but there are so many complications that plastic surgeons didn't do it, but then it's revived recently because of that. People are complaining about some animation. But I believe animation can be minimized. But anyway, if you do it above the muscle, then a lot of times you have to do fat graft at the same time or do it multiple times to make sure that implant looks not artificial. and it works best in people with a lot of subcutaneous fat. Did I answer your question?
Yes.
I've had an effect. And as far as the reconstruction goes, you don't use the skin that's here, you don't use, right? So if you take the skin in the stomach, or how does it?
You mean your own skin? Your breast
I've
skin?
had a mastectomy.
Yes. But you didn't have a reconstruction then?
No, I haven't had anything.
So depends on what technique you choose to reconstruct your breast. Oh, the question is, if you didn't have a reconstruction and you have your own skin there, what can you do about the skin? Whether you need to add skin or use your own skin, yeah. So you can either stretch your skin, like with tissue expander, and do an implant, or you can use your own belly fat or your own tissue to create a breast mount. So there are two different ways to approach.
And how long? I'm in the middle of doing finishing up chemo. So how far after chemo do
You have to wait at least a month to make sure that your white cell count and all those things are recovered enough for you to undergo a surgery. So.
My question is the same, except that how long after you had the mastectomy can you go for reconstruction? Mine was a few years ago.
Anytime. So we see patients that come in with and want reconstruction 10, 11 years after their mastectomy. You can always have reconstruction. There are options. So we've had patients that came in 11 years because at the time of their mastectomy they had young children and they just weren't ready to go through all of that. They just wanted to treat the cancer and be done. And then came back when they were in a better place to undergo reconstruction. So there's no time limit on if you don't do it in this period of time, it's not an option for you.
I guess it doesn't make a difference in terms of how much skin was there or stuff like that, but in terms of
How much?
I see. So if you're, yes, because I think that Dr. Choi would agree, if you put a tissue expander in under someone who's had a previous mastectomy, and especially if they had radiation in the past, there's only so much you can stretch the skin safely. It could get too thin. So a lot of the times in patients like that, tissue reconstruction is the better option to replace the skin. But if you were okay with having a small reconstructed breast, then a tissue expander to stretch out that skin a little bit and then put a small implant in would be a good option. And one thing to mention, we talked a lot about tissue reconstruction. It sounds great. You have to be a candidate for it, meaning have the tissue and be healthy enough to have a big surgery. If you have other health issues going on or mobility issues, you might not be a candidate for that tissue reconstruction.
And we will tell you. Yes. You have a question?
Yeah, I have two questions. Will they still have to replace implants every 10 years or every how many years? And the other question is, after 6 years of the reconstruction, surgery reconstruction with unilateral implant, and that breast looks, the implant looks like not natural, what do you do with the patient? And then the other breast is natural. Yeah.
Yeah, the question is basically sometime after reconstruction, the reconstructed breast looks asymmetrical, not symmetrical to your natural breast, and what can be done about it is the second question. The first question is, do I have to change my implant in 10-year mark? So you don't have to do that. You don't have to change your implant unless there's a problem. You could have a capsular contracture, the hardening of the breast. That's one reason to change it. If the implant is leaking, that's another reason. If you need a bigger implant, smaller implant, different implant, that's another reason. But if you're very happy with the implant, you don't have to change it. In a case that they no longer match,
Never have to change the implant. You could never change.
if they're not leaking and they're comfortable, you never have to change it. But if they're very asymmetrical, then you have to either add tissue to that breast, reconstructive breast, like the flap surgery, or from the back, or implant, or put a little bigger implant, or lift the other breast, or reduce the breast, depends on your desire and your wish. The plastic surgeon will go over your options with you and what makes best sense for you.
Only one more question. If you have one plastic surgeon at NYU, can you see other plastic surgeons at NYU? Or
yes, it's okay.
Hi. For the sake of the audience, full disclosure, I am Dr. Axelrod's patient. She has performed over the course of 10 years, 2 mastectomies. I underwent one this year earlier and one 10 years ago. So, and I am also a patient of Dr. Dr, who is Dr. Choi's colleague. They practice together, share a practice. And I'm not sure if I'm describing the relationship.
It's sort of like that, yeah. We share the office, yeah.
Okay, so let me have you met Dr. Choice. It's
Nice to meet you.
My question is this, and Brooke filled my tissue expander, so.
So you're bosom buddies.
Yes. So this is a very timely event because I'm very soon meeting with Dr. Hart, having just completed my course of chemotherapy followed by 5 weeks of radiation, which just ended. So I'm recovering from radiation at the moment. So when I now will speak with Dr. Clark, we've already determined more or less the course of action as far as how, that we will be doing reconstruction. But this is my question. So I have one breast with a 10-year-old implant, and that will be removed. And then I will receive 2 new implants, one of which will be removing the tissue expander and so forth. This is my question. I'm trying to gauge how complicated the actual surgical event will be, given the fact that the 10-year-old implant, when that reconstruction was done, it needed a revision because the implant there wasn't enough support. And the revision was using the cadaver tissue to create the sling. So now, well, on the older side, the older implant, what's going to happen with unwinding all of that construction to put in the implant?
So the question is, do you have to take out the alloderm, or can you just swap out the implant?
That's right. And how complicated is it to do this? Now, I'm asking this as a second opinion. Dr. Clark is wonderful. He did a terrific job.
Well, just theoretically, could you swap it out?
Absolutely. It really depends on how you look, what your symmetry is. So if the symmetry is good right now, he can simply take the old implant out and put new implant in there. If the symmetry is not good or can be improved, then he can take, the alloderm is completely integrated into your tissue right now.
Right.
It's healed together. So you could remove a little bit of it, or you can remove all of it, depends on what you want to achieve. We call them modifying the pocket. So you can modify the pocket. They can be stitched, they can be widened, they can be narrowed, they can be lifted. Many things can be done. So he will do what is necessary,
I didn't know whether, this is going to be, when I had the reconstruction, I've only had reconstruction in like 10 years ago. It was an outpatient ambulatory procedure, and I'm anticipating, and I think I've been told that, again, it will be an ambulatory procedure to do this. But my thought was, because of the complication of the construction of the prior situation, is it likely that I would have more of an extended recuperation time in the hospital, being admitted as a patient?
Unlikely, but if he has to do a lot with your alloderm, then healing process may take a little longer. But it's usually done ambulatory procedure, so you probably don't need to stay in the hospital.
And are drains ever a part of this reconstruction?
Usually not. Usually not. So
I
it should be. Yeah.
Okay, I think we're going to wrap it up. And I want to say a big thank you for standing in and doing such a wonderful job.
Thank you so much for
Being an
having
excellent
me.
colleague. And I also want to thank Brooke
Yes.
for being stupendous to our patients, being a great asset and a great advocate. Thank you.
And I would like to thank Dr. Axelrod for hosting this meeting. And she just, like, as we all know, she's a wonderful doctor and colleague, and I would like to thank her especially.
One more thing. Thank you to Cher for co-hosting with us. Thank you.
Yes. Thank you so much.